Great. Alana, I'll pass it to you.
Myself. Hi, everybody. Thanks for coming. So we're going to get started with our final presentations. We've got some great judges on board. So welcome to Beat the Pandemic 2, the new hotspot nursing homes and assisted living facilities. We'll do next slide. So we go back to the judges slide, I guess. So we've got a lot of partners, a lot of really, really awesome groups have been sponsoring this. So we can thank them for their support in terms of different, just basic support, things like Airtable and then also the financial support. So our track judges, and I just want to pull up their bios here really quickly. We have been really fortunate that we have some really fantastic judges. So I'm just going to go through and give you a brief introduction to each of them. And I may be going out of order of what's listed there, but so we have Abid Siddiqui. So he's a consultant with the Biomedical Advanced Research and Development Authority, or BARDA. Some of you may know it. They source new technology for health and human services, and they fund them. And just correct me if I'm wrong, Abid, if I leave anything out. So before he started working with BARDA, he has a background in management, corporate finance, and strategy. So I think we're really fortunate to have him here judging with us. We've next got Nate Bayer. He's a managing director and partner at Boston Consulting Group Digital Ventures, so BCG Digital. I'm sure all of you had some interaction with BCG over the last few years. He's had 20 years experience in healthcare across research, startups, and consulting. So he's going to have a really great digital and kind of technology business perspective to bring to this. Suzanne Shirley is a licensed clinical social worker. She's the director of partnerships and community engagement with the Veterans Health Administration Innovation Ecosystem. So the VHA is a large organization and they have different subparts. She works to expand partnerships with industry, academia. She promotes design thinking to solve challenges at the VA. They also help to test, validate emerging technology solutions that will be applied then within the VA system. She also helps to scale new care models all throughout the organization. And with her background as a clinician and administrator, she's a systems engineer and entrepreneur. So she has many, many hats, but also many, just a depth of skills and talents. She brings a really great patient experience and systemic consideration to the design and development of innovative healthcare solutions. So she's participated in other hackathons, community summits, innovative design and demos. And she really is going to be able to help us bring some innovation and perspective from government and academia across disciplines. And then lastly, we have Sandeep Gupali. Sorry if I mispronounced that. So Sandeep heads up the Global Medical Epidemiology and Big Data Analytics Center of Excellence at Pfizer. He also leads a data science team that develops a novel data-enabled approach to contextualize emerging diseases for every stage of drug development. The life cycle of it is pretty long, as most of you know. So they also help to accelerate development of next generation Pfizer therapies. He was also, interestingly, a White House Presidential Innovation Fellow for the NIH. And he just recently helped President Obama's Precision Medicine Initiative launch. So he's been the founding member of many innovation groups at Texas Medical Center and Massachusetts General Hospital. So those are our fantastic judges. And judges, we have some really awesome teams coming up. So we can go to the next slide. So this is the hackathon process. People pitch some ideas on Friday, then from basically Friday night at like 8:30 or 10 p.m. Eastern Standard Time, whatever time zone everybody else was in, they mixed, they mingled, they tried to figure out what ideas they wanted to bring to the fore. They wanted to create new ideas, and then they started to form teams. So about 10 a.m. on Saturday, they registered their teams, and then they just hacked away for the last, 18 to 20 hours. We were able to give them feedback throughout the process, and hopefully, they were all able to put together pitches, which you'll be able to see now. But we also tried to help them with mentors and other resources to really solidify their product. So they should have a minimally viable product or idea. And this process just kind of went on until they came to the point where they are today. So then they'll be presenting their final pitches. And we've had some other some of these other things. So the judging criteria will include, so for the participants, this may be the first time you're really getting a good look at this, so I'll try to go quickly but slowly. So there are 4 different areas: the impact of your project, the innovation, how it's implemented, and obviously your presentation, which you guys have been practicing. So questions regarding impact are, does the solution solve a real problem? So there's a potential for widespread public impact, public health impact, is that there? And then do we see that you're addressing an important challenge that's identified in the prompt? So this is all track G, so the prompt is specific and you need to have designed things for that. Regarding innovation, so what are we looking for? Does the team provide a convincing rationale for why their solution is going to work? And does it address significant technical issues that are relevant to their problem? Does the solution consider user experience, interface, and service design? So we have a lot of UX, UI people that have been helping with those types of things, but the ideas have to be good. And then regarding implementation, is the proof of concept, prototype, preliminary vision, could it actually be executed? Is it something that's just pie in the sky, or does it look like it can actually be done? Is it sustainable? Is it viable and feasible? These are not things that are just for the hackathon. We're hoping that you came up with solutions that'll live outside of the hackathon. Could a solution possibly be implemented by one of the challenge partners? And then lastly, the presentation, is it effective? Does the team have what it takes to carry out the project and implement it afterwards? Does the team have the diversity of backgrounds that lend themselves to the solution area? So next slide. So for logistics of these presentations, you are being recorded, which you know now, and if you agreed to it beforehand, you should, if you don't agree to it, you should let us know. There are multiple team members who can present during the presentation part and who can answer during the Q&A part, but you guys should have practiced this and you should know how it's going to go. You'll only have 3 minutes, and we're going to be strict about that for the presentation, and then 2 minutes for your Q&A. We will cut you off in the middle or in, you know, when you're doing your sentences. So try to make sure you've practiced that. The order you present is random. So we will tell you that you're up next and you'll have 5 minutes to prepare, and we're not going to budge from that. So you're not going to know several ones in advance. If you're presenting for your team, what you're going to do is raise your hand, and you should be able to see a little icon with a hand that you can raise, and then we'll let you know that you can be unmuted, or we'll unmute you. So I believe Alfonso's going to do that. When it's your turn to present, you'll either unmute yourself, or if you're having trouble, we'll unmute you. Turn your video on if you want to, and then Alfonso will flip through your slides for you. And then as the track lead, I'm going to be, you know, doing this part of it. I'll give you a 1-minute warning. So I'm going to hold up my cell phone, and you'll see, you know, 1-minute warning there before your presentation is up. The judges will then pick 4 winners at the end of the track. I'm sorry, at the end of the presentation. So 4 winners per track. All right, so to reiterate, you're going to raise your hand. You should look for that little blue icon. You're going to wait for the host to unmute you, or we might allow you to unmute yourself. We'll let you know if there's a problem with you unmuting yourself, and then we'll mute you all. And then you'll have 3 minutes to present and 2 minutes for the Q&A. So with that, I believe we're going to go ahead and get started. So team 18, Elevate Elderly, is up, and then the next team after that is going to be Spara. So you have 5 minutes, Spara, to prepare. So go on ahead, team. Oh, actually, let me get my clock up. All right. So team Elevate, you can go ahead and get started.
Hi, I'm Monique Wong from Elevate Adult Care. Nursing homes have been fighting battles on their own. They need a way to collaborate and reduce the burden. Next slide. This is us. We're innovative, collaborative, and diverse. Next slide. Care providers use multiple systems and tools to care for patients. During crises like the current pandemic, they use all the systems more heavily and also use additional systems. Basically, they're switching back and forth, logging in and out, and wasting a lot of time and energy. This is unsustainable. Next slide. Our solution, an easy-to-access portal integrating disparate systems that addresses the pain points. This centralized portal will conservatively save an estimated 30% of providers' time and $2 billion in facility spending. This solution was validated by care physicians, administrators, and domain experts that we talked to. Next slide. With the pandemic, there's a dilemma of how to safely visit elderly loved ones. To facilitate safe visits offset from other visitors' times, we are creating the Family Visitation Scheduler, where providers and visitors can schedule staggered time slots. Providers can further track and manage visits. Next slide. Surveys identify that tracking the usage, forecasting demand, and optimizing stocks of PPE is a critical need. The PPE Manager dashboard reports data on PPE inventory, forecast burn rate, and auto-generates invoices to order through the supplier network. Next slide. Providers receive COVID-19 data updates from multiple disparate sources. Care facilities are now mandated to report COVID-19 case and death numbers, but that data is not centralized. Our dashboard consolidates those sources. At a glance, providers can observe trends in case spikes and among facilities. Next slide. Residents would usually ask repetitive questions to staff who are already overburdened. The chatbot will be trained to take on this role, freeing up staff for essential care. Next slide. I mentioned the multiple functionalities of the Elevate Adult Care Portal, and I want to reiterate that providers, residents, and families all will have access to and benefit from the portal. Next slide. So the architecture is designed for easy deployment, access, and management. Next slide. The proposed timeline to get us to an MVP is in the order of months. Next slide. So fragmented systems have complicated the COVID-19 response, especially for adult care facilities. Elevate Adult Care sets up infrastructure to optimize operations so providers can focus on the people who truly matter. Thank you so much for the opportunity to participate and present, and we're excited to move this forward.
Sorry, my bad. It was thing. So now you've got your 2 minutes for your feedback from the judges.
Okay.
Hi, this is Susie. This is a great presentation, and I really like how it's clear you gave some thought to what are some of the biggest challenges that healthcare systems are facing in terms of managing information. And you know, in the VA, of course, we've given a lot of thought and energy toward PPE allocation and distribution and understanding those things and visitation and stuff like that. So I really like the approach, and I'm wondering a little bit more about your business model. You know, how will you navigate kind of the IT systems and things like that and get healthcare systems to buy into this?
Yeah, I can take that. So this is just an add-on. It's just an interface. It's really bringing together all the IT systems, which we're very cognizant of. So it's really reusing a lot of the technologies that they're using and just bringing it together. It's really a consolidation of all the existing functionality. So if they have it, we can interface with that. If they don't, we can help them build that.
How did you down select to these features?
Sorry, I didn't get that.
How did you guys pick these features?
We actually as a team had a lot of ideas, and I think that it's an endless set of possibilities. We looked at the most impactful, the quickest to implement, and that was some of the criteria that we used.
I would like to extend that just a little bit. We had some consultations, met with medical directors and quality directors from some of the large centers. And we're also identified by them something that's more an immediate need.
Right, absolutely.
I have a quick question around the chatbot function. I appreciate you kind of trying to reduce the burden of some of the workers there.
I think unfortunately we're out of time for the Q&A section. Sandeep, Alfonso, if that's how you want to run things. So I apologize. We have to move on to the next team.
No worries.
Thank you.
Yeah,
Thank you so
Sandeep,
much.
Thank you, team. What I'll note is that
you.
you should all have access to a form you're using to provide your annotations on the team. That'll help us determine the winners at the end. As part of that form, you should be able to provide feedback to the teams, which is something crucial here, something that teams really, really use. From all of our previous events, teams always look forward to seeing the feedback that the judges in this case provide. So that question, it's captured in the feedback, and also any other feedback that would have, let's capture it in there.
Yeah, and we can definitely answer those questions offline as well.
Thank you.
Okay, so we're gonna go
for
now.
participating, everyone.
Our next team on the line is Spara. And
Yeah.
just for upcoming, well, as you can see on the slide, after Spara, we'll have Guardian Angel, just so that you're ready. But right now, we have Spara.
Okay.
Hey, can you guys hear me?
Yeah, so we're ready for you. I can start the timer now.
Perfect. Is it okay if I do like this? Whoever's watching the clicking, is that okay
Yeah, that's fine.
for the next? Cool. That's faster for me.
All right, so I'm going to start your timer now.
Hi, everyone. My name is Hazel, and I'm part of Team Spara. We're reimagining staff health protection using an AI-powered biosensor platform to detect early elevated temperature. So long-term staff are putting their lives at risk every day to take care of the health of the elderly, and rates of infection and death are extremely high, with fever being a symptom. In 89% of the cases, temperature has become a critical element to assess staff health. Next. So talking to healthcare leaders, we found that many nursing homes don't have a way to protect the health of their staff despite them being at high risk of contracting COVID. Next slide, please. We've talked to a lot of healthcare leaders and we found out that self-reporting takes up a lot of time, and having temperature screened by other staff increases overall exposure. And then sometimes staff are so busy going from site to site and taking care of patients that they can be running a fever and not know until 10 hours later. So this creates a significant number of potentially preventable infection situations that puts their residents, coworkers, and family members at risk. So what we found was a large gap in the market for continuous accurate temperature monitoring, which is why we created Spara to take a completely different approach to proactively managing elevated temperature amongst staff to reduce symptomatic infections. So you can just click it and it'll obtain that. So Spara is a comprehensive system that quickly connects health data from sensors of camera, selfie station, and wearables. It pushes alerts to a mobile app, and it syncs with a desktop application where admins can manage staff exposure risk all in one place. So here's how Spara works. Let's go through a use case. Take Dawn. She is a long-term healthcare staff worker. So in the morning when Dawn wakes up, she enters in her symptoms into her mobile phone, and that's her first screening, and she's allowed to come on site. When she gets on site, she holds up the phone to her face at the thermal check-in station, and it records her temperature and logs it to her account. And then we have wearables that push alerts if she has elevated temperature, and her manager gets notified if he needs to schedule a replacement for her. So Spara is unique because we have camera AI that allows us to have anti-facial recognition in the thermal space and move as a wearable with industry relationships that we currently have. We plan on using a SaaS business model in order to make long-term facilities easier to adopt and scale the solution. And we also plan to make wearables the first available on a B2C basis, so healthcare can start using this immediately on the staff level and then expand into additional high-impact healthcare verticals. So our team is made up of grad engineers specializing in AI, and we've had experience working with high-risk vulnerable populations for the largest reproductive care in the country. So now is the time to quickly move in order to have the answer to protecting health worker lives. Next. And we invite you to join us.
You're out of time. Thank you. We'll go on to the questions section now. So you've got 2 minutes starting now.
Great. Thank you.
Can you, oops, sorry, go ahead.
You go.
Can you dive a little bit deeper into the business model? I think for me, that's something I'd love to learn a little bit more about, because I think many of these nursing homes and assisted living facilities may not have the budget to implement something like this. So have you kind of thought about some of those hurdles? And
Yeah.
I know you mentioned a SaaS platform, but a SaaS pricing model, but just dive deeper into for that.
Yeah, so I work for the 4th largest private owner of healthcare in the world, deploying scalable solutions across over $4 billion of real estate. So there's 2 ways we can do this. One is through the subscription model on the wearable basis. It's a monthly charge or an annual fee, so we can scale that up pretty quickly. Same thing with the kiosks. And so with the kiosks, we make that leased equipment. So it counts as an operating expense that they can write off instead of a capital expenditure. And this can also be additionally subsidized by the real estate owner and operator as a CAM kickback to their lease.
Can you talk to the wearable a bit more? I'm not sure I completely get it. I get the camera.
Yeah, so the wearable, we've identified 2 partners in this space. One is the size of a silver dollar, and it goes on a chest strap. So it measures core body temperature, which is the most accurate measure of temperature. The other one is a very lightweight in-ear device, and we've cut in the manufacturers, and we're trying to get the cost down to be sub $100 on that basis. So we want it to be extremely affordable for everyone, so no one has to pay or have the money to be protected.
Wait, so why do you need both? Why do you need the camera and the wearable?
So the camera also can screen visitors coming in. So that's a second use for that, and it's an entire modular package. So you can scale out or downscale depending on the complexity of the deployment.
And with that, we are now out of time for your section, but thank you. So we'll move on to the next group.
Thank you.
Yeah. So we can go to the next couple of slides. So we've got team 3, Guardian Angel, up now, and then up next is team 27, Save Eld. So you have 5 minutes to prepare Save Eld. Okay, Guardian Angel, are you ready?
Yep.
All right, I'm gonna hit the timer now. Got
Okay.
3 minutes.
Okay. We present to you Guardian Angel Recovery Accelerated by Protecting the Most Vulnerable. People are dying of COVID-19 in nursing homes. Because the most vulnerable are highly visible, reducing their death makes a great impact on the overall recovery. Currently, to reduce transmissions, the CMS guidelines recommends triage and separation of residents based on their COVID risk status. However, staff and nursing homes could still expose residents to COVID, exposing them at great risk. We are installing Guardian Angel, an automated administrative system for patients and staff grouping. The key innovation in Guardian Angel is the concept of pods. We group patients and staff to reduce transmission and cost. Currently, nursing homes screen their staff members at the door, which only captures symptomatic staff. We aim to reduce asymptomatic transmission from staff to residents by creating partitions or pods. We introduced the Guardian Angel app for staff members. For example, our nursing assistant will be guided to work within a designated pod based on their risk and the risk of the colleagues and residents within that pod. Each pod would have its own set of rules. Individual staff app activity will be reported and aggregated as a facility to a dashboard. The dashboard will be updated to modify policies at the pod level and train the staff accordingly via the app. Based on the analytics of the tracking data, a safety score will be calculated for each facility and made public for patients, family, and discharge planners to see. Along with the safety score, a detailed report, I think there's something duplication. A detailed report of the facility will be made available to the public. Our value proposition is quality improvement, a marketing tool for the nursing home facility. To ensure privacy of our staff members, we will use SafePath technology from MIT. Understanding some nursing homes are too small and understaffed to implement our proposed pod structure, we offer solutions by allowing collaboration between small nursing homes. We plan on having a working prototype in 4 months. We deliver to nursing homes our Guardian Angel suite to make them more efficient by reducing compliance network, make them more engaging with constant updates to the dashboard, and more competitive through continuous improvement. We combine world-class leadership in digital identity and privacy practices, healthcare industry entrepreneurship, and current data science techniques.
Thank you. Your time is now up, so we'll move on to your questions.
Thank you.
So I'm going to start the timer now.
Can you talk a little bit more about the tracing of I think you said something about contact tracing, so I'm just curious on how that applies
to
technology.
Yes, so this MIT-led project called COVID Safe Paths is dealing with contact tracing, both with proximity detection and location tracking. Right now, those are 2 separate apps. They are in discussions with Apple and Google to merge them. And we're building Guardian Angel as just an add-on or an implementation of that open source project.
Thank you.
can you talk to business model?
You want to take that, Adrian?
Yes, please.
So who's paying for it and how are they paying for it?
Actually, yes, it's the facility is paying for it. The nursing home, the long-term care facility is our customer completely. It keeps things simple. They're the ones that benefit through better marketing and better utilization of their beds.
You mentioned 4 months to a working prototype. Can you tell us a little bit more about what those 4 months include?
Basically adapting the COVID Safe Paths app to demonstrate the dashboard, right? Because they're feeding the information to the dashboard, and then to update the policies that are recommended for the alerts that you saw in the app. So the app has these two add-ons, right? The infrastructure.
Okay, so we're now out of time for the questions if you want to continue it later, but thank you for your time. We'll move on. So team 7, Save Eld, and then up next in 5 minutes is Care Owl. So Save Eld, if you're ready, you can go next to their first slide. And Save Eld, I'm going to start your minutes when you tell me. Is there someone on from their team yet?
I'm sorry, Alana, which number is this?
It should be 7, team 7. And
Shamir,
then
you have your hand up. If you're part of this team, feel free to.
Oh, I am belong to team number 10. Sorry.
Oh, okay. So Save Eld, if you're not ready yet, we might have to move on. Team 7. I don't see the gallery view, but
am I on mute? Are you
team 7?
Can you hear me now?
Anna, we can hear you, yes.
We are 27 actually.
We're looking for
Safe Alpha.
Yes.
27. So yeah, we're ready.
Okay, great. All right, so I'm going to start your time. Sorry about that. There was a typo then in the presentation. I'll start your timer now. You have 3 minutes.
Okay. Hi, we are Safe L, and the problem we are trying to solve, as everybody knows, 42% of the COVID-19 death is actually happening at the nursing homes in the US, and they can be as high as 81%, right? So, but it's not necessarily the case. If we look further, right, in some other parts of the world, what can we learn from somewhere else where they have no death in the nursing home from COVID-19? So what are the opportunities for improvement? Next slide, please. So the problem here is, as we zoom into the problem, we look at 2 groups of users in general. It's the elderly residents and also the caregivers in the elderly home. Typically, there is a lot of physical contact when these caregivers take care of the elderly. So that basically is also a way for the virus to spread. So the problem is, how can we prevent or provide comprehensive care for elderly people without infecting them with the viruses? So the countermeasures for COVID-19 is very familiar to everybody, right? We know the tests and tracking symptoms, contact tracing, and then asymptomatic carriers is a problem, right? But we can try to do that, counter that by having habits to keep hygiene and prevention. And so if we look all around the world, there are lessons to be learned, and most of this is tracing back to the individual behavior. The individual behavior on how they presenting themselves, protecting themselves from COVID-19 is actually something we can learn and apply to this case in the for the nursing home. Sorry about that. Yeah. So let's slide, please. And so this is a list of pictures, but let's go to the next slide where we can see the mock-up. So this is a very easy to use app for the elderly residents to use on the tablet, and they can connect with their family or the other friends or caregivers using this video call, or they can have some fun and enjoy themselves, or they can do check in with the health on their health with the caregivers, like here in this other screen, and also they can be ordering meals using this mobile app. And so this is more details on their personal health record. So if there are some health conditions that are serious and require attention, the caregivers will be notified and they will get the attention. And this is more screenshots on the time trend of the health.
You're out of time now, so we're going to have to start your Q&A session now. So that'll be 2 minutes.
Thank you.
Yep, and we'll start that now.
So is this largely around patient clinical data management?
So this is mainly specifically in this particular case is for nursing home, right? But for sure, it's for outpatient, is when the patient is anywhere because they are carrying this smartphone or tablet where they have this app running, so they can be keeping track of their health conditions anytime, anywhere. So if the goal is for outpatient, covering the time in between the doctor's visit, they can have their own record in a continuum of the healthcare environment. So
in the patient data that you're collecting, is that being held on the cloud that you guys would own, or is that data kind of held on site and you guys pull some de-identified data set? Yeah.
Sure. Good question, because privacy is the core of the by design, we want to enable privacy. So we don't just put it in any cloud. So right now it's on device and they can store it on premise as well. But we can provide different options, right? First, it has to be on device, right? And then what if there is no internet connectivity, right? So we have to be able to have that information and use that application in the case when there is, for example, disasters, right? So, but backing up to the cloud is possible.
Well, we've got about 10 seconds left. I don't think that's enough time for another question. So maybe we can, just end there. And then the next team up.
Well, I can just, if I don't mind, I would just mention that there is the remote patient monitoring, the care
I think you'll need to communicate outside of it for that. I'm sorry that your time is up though, but we do need to move on to the next team. But thank you for presenting and I appreciate it. So the next team up is 006 Care Owl, and after that we're going to have 002 Go Mild. So Go Mild, you need to get ready to be on deck in about 5 minutes. And Care Owl, if you're ready to get started, we can.
Can everyone hear me?
Yep.
Great.
I'm gonna hit start.
As a nurse, I can tell you firsthand that frontline long-term care workers, such as certified nursing assistants and registered nurses, are facing numerous challenges during the era of COVID-19. Next slide. Such as Jennifer, a CNA at a local nursing home and a low-income mother of 2. Jennifer is feeling scared of spreading COVID-19 to her family. With an overwhelming patient load, currently including 4 COVID-positive patients, coupled with her limited experience working with infection control, Jennifer wishes she could find an easy way to gain expert advice and support for those working in long-term care. Next slide. Sadly, Jennifer's scenario is one shared by frontline workers around the world. These underpaid staff members are facing great anxieties around COVID-19 and are feeling frustrated when attempting to keep themselves and their families safe with such limited training and up-to-date resources at hand. And that's why we created Care Owl. Next slide. Care Owl is a web and mobile platform serving as a one-stop resource for frontline workers to exchange the best practices and support during COVID-19. We believe our platform, which provides peer-to-peer resource sharing and gamification incentives, will improve staff safety, decrease staff anxieties, and improve patient care. Please see our full prototype at bit.ly/CareOwlMVP. Next slide. Jennifer heard about Care Owl from a colleague and was excited to submit a question regarding how to best decrease the transmission of COVID from her work facility to her home. Jennifer feels reassured and empowered when a Care Owl certified frontline expert responds to her question and links to a learning module that is publicly accessible. And it doesn't stop there. Since Jennifer submitted a question on our platform, we've rewarded her with a free Starbucks drink, which will help her stay engaged with our platform. Next slide. There are 2.8 million frontline long-term care workers just like Jennifer that can benefit from the community, resources, and tailored COVID training that Care Owl offers. Next slide. In terms of our business model, Care Owl is committed to remaining free for frontline health workers. However, we will remain sustainable through 3 ways, including partnerships and a premium model once we scale. Please see our appendix for a detailed go-to-market strategy. Next slide. As compared to the current market landscape, Care Owl offers the first way for frontline health workers to provide peer-to-peer collaboration, focused specifically on COVID-19 challenges in long-term care facilities. While education materials exist on the market, these products are general and hard to navigate for busy frontline workers. Trust me, I would know. Next slide. The Care Owl team has designed this platform to be scalable, helping us reach our goal of making an impact for frontline workers around the world. Next slide. Our team of Care Owls is ready to leverage our diverse capabilities to bring our product to market. Next slide. Our platform provides impact on both an individual and public health level. When frontline health workers feel supported, informed, and empowered, they can lead the way in improving patient care and decreasing the spread of COVID-19. Thank you.
Anthony, oh, great. You ended just on time. So now we're gonna do your questions, 2 minutes, starting now.
This is Susie. Great presentation, great solution. I think it really speaks to an unmet need where frontline workers really need access to good information in real time. So tell me again about the business model. Who pays for the app in the beginning? Is it the healthcare system for the individual?
Trevor, are you there?
Hello? Hi. So I can take this first of all. So our initial plan for our 4-stage go-to-market strategy is first we're going to run a pilot project with a partnership with an academic institution or large nursing home chain, hopefully in the private market, gather user requirements. And so this is immediately implementable over 1 to 2 months. And eventually we plan to leverage other revenue streams as we build up our capabilities. We add on extra features and can therefore integrate partnerships with white label app usage, collecting more data on these frontline workers, and eventually with partnerships with health insurers to provide more information. And as we demonstrate our cost savings and improved outcomes, we'll definitely demonstrate our ability to save money and improve elder care.
So is there an ad way? I mean, content is usually monetized through ads. Is there a way to do that?
Yeah, absolutely.
Make
We
it
can
faster?
definitely integrate ads into our platform, specifically tailoring to frontline workers. So that's definitely an option as well that we could explore.
And in addition, the gamification enables a huge opportunity for partnership with consumer goods companies to provide rewards.
And with the peer-to-peer sharing model of your best practices, I mean, have you guys thought about the governance of some of the best practices that are being shared and making sure that, not proliferating,
Okay, we're out of time for this section.
We have thought of that.
It's in the
We'll let you guys go on ahead and continue this conversation maybe after. But thank you guys for your help, and we'll move on to the next team. So team 002, go mild. And then the next one up is going to be 011, Staff Optima / Riskify. You can get ready for 5 minutes, but go mild. Are you ready?
Yes, I'm ready.
Okay, perfect. Why don't we go on ahead and go to the next slide then for them. And go mild, I'm going to start you right now. So your 3 minutes starts now.
Our team Go Mild is committed to reducing the severity of COVID-19 in nursing homes by improving resistance to infection. Next. 42% of US COVID-19 fatalities are in nursing homes, and 27% of the elderly who contract COVID-19 die. Up until now, society's been focused primarily on trying to eliminate exposure, but it's almost impossible to eliminate all exposure. Next. There's another side to the equation, to reducing risk. 73% of elderly and 97% of all ages do withstand COVID-19. What protects them? Next. Perhaps it's their immune system. Knowing some nursing home residents will be exposed, how do we strengthen their immune system to have a milder response? We can turn to existing clinical guidelines that can safely provide protection. Next slide. We know from a multitude of studies that vitamin D improves bone and muscle health, reduces depression and risk of cardiovascular disease. And even more important for COVID-19, it has been found to reduce risk of respiratory illnesses in elderly population by 40% and decrease pro-inflammatory cytokines. There are also a multitude of studies of vitamin D and COVID coming out of Europe and other parts of the world. One study found that people with insufficient vitamin D were 7 times more likely to die. Studies are underway in the United States to evaluate vitamin D for treatment of COVID. Next. Nursing homes have a huge problem, and that problem is high deficiency in vitamin D. We have good reason to believe that this makes residents more vulnerable to COVID-19 mortality, yet we already have safe, accepted clinical guidelines for maintaining minimal levels of vitamin D. These guidelines do not need to wait for COVID-19 clinical trials to complete. Are we contributing to unnecessary mortality? Next. We can create an implementation blueprint that makes it easy to follow clinical guidelines, starting with universal testing for vitamin D levels in nursing homes, supplementation as needed to meet minimum levels, measuring the fidelity of execution in the nursing homes, and measuring outcomes. Next. We would start by implementing vitamin D guidelines in 3 early adopter nursing home networks that are influential and respected, 1 site at each of them. And then out of that, we'd have case studies, we'd be able to course correct. Those nursing homes would roll out in phase 2 to their entire networks, and simultaneously we would take the positive case studies to the National Nursing Home Associations, who would support their members to implement in order to increase revenues and customer satisfaction. There are already payment incentives for better health outcomes, and we could consider providing additional incentives due to COVID-19. Next slide. COVID-19 and other future pandemic exposures will happen. Following safe vitamin D guidelines increases resistance to infection, and existing healthcare funding supports our implementation blueprint. So how can we not do this? Next. So we'll leave you with a quote from former CDC Chief
And
Dr.
you're out
Tom
of time
Clayton.
now, Vanessa.
Thank
so
you.
We're gonna go ahead and stop there. And now your 2 minutes for Q&A will start.
How would a clinical trial fit into your implementation plan?
We didn't include that. It could be included because any of the nursing homes that did this, there could be an associated clinical trial that would drive up the cost of doing this. And our argument is basically these clinical guidelines are already what should be happening, and they're not. So we're actually not proposing like high dose vitamin D that's about killing COVID. We're actually saying just get their vitamin D levels up to what they're supposed to be already, which is just 30, which most people would argue is on the low side anyway.
Yeah, it's funny that you put this out, because I just saw a study about this morning about how important vitamin D was. How do you think about it from the business model perspective? Because this is essentially a guidance, clinical guidance, right? So how do you turn this into a business model and something that scales?
Well, we think it already sort of is a business model, because our understanding is that Medicare and Medicaid and most health insurers would actually pay for vitamin D testing and vitamin D supplementation because the clinical guidelines already exist. And so most of it would be paid for. Obviously, there's initial, we estimate about 50,000 initial upfront costs of like working with the first healthcare centers, nursing homes rather, to implement this. But also when you compare it to the cost of hospitalization of elderly patients with COVID-19, and also the shutdowns that we've done economically in the trillions of dollars, if you offer a small incentive, additional incentive, it pales in comparison.
Okay, well, we have about 15 seconds left. If someone wants to jam in a comment from the team, I don't know. Otherwise, I guess we can go on ahead and close it out. And then the next team up is going to be team 11, Staff Optima, Riskify, and 024 vBot should get on deck. You'll be up in about 5 minutes. So team 11, are you guys ready? Shall we move to the next slide?
Hi, yeah, okay. I'm ready.
Okay, I'm starting your timer now. You have 3 minutes.
Okay. So hello everyone, I'm Blanca and I'm excited to present Staff Optima to you. Next. So can you believe that almost 30,000 people in nursing homes have died from COVID? These statistics are scary and clients are distressed. Next. So where is the problem? Well, part of the problem is that there are workers who may be infected coming in and out of nursing homes. There is a significant proportion of asymptomatic workers who go undetected. So why aren't we testing staff properly? Simply put, testing is expensive and unavailable. So our mission builds from this and is to make clients and workers feel safe. And we want to do this by optimizing testing strategies in nursing homes. Next. So what are we proposing? Our solution is Staff Optima, a SaaS platform to offer nursing homes an individualized testing strategy based on staff risk and the testing resources that are available. Next. So what are we proposing? Our solution, so this is like what our solution looks like in terms of like risk stratification, like assigning it to higher or lower risks, and then building on from that to inform upon like regular individual testing or pool testing, depending on the risk. Next. This is what it looks like for care workers. It's a quick daily questionnaire that assesses risk of infection based on things like symptoms, exposure to confirmed or suspected cases, and lifestyle factors. At the end, there is a recommendation regarding when and how to get tested. This is made engaging through competitions and awards. Next. From the nursing home side, an administrator has a dashboard and can see how many workers are high, medium, or low risk. Using the nursing home budget and risk calculation, Staff Optima allocates resources on an individual or pool testing basis to workers. Finally, we coordinate the strategy with third-party testing facilities, ensuring that there is trust as data is anonymous and there is no discrimination in the workplace. Next. Our tech stack consists of React.js and will consist of React.js, Node, and for web application, Ionic for cross-platform mobile application, and Firebase for centralized database. And this will allow us to detect new outbreaks early, optimize test kit use, and improve the well-being of healthcare workers and residents in a way that no other platform can achieve at the moment. Next. Our entry market point includes 1,500 nursing homes that had COVID outbreaks and would be interested in ensuring that it doesn't occur again. Our regular pool testing strategy is 90% cheaper than the current solution. This is key because price is a main barrier. Next. We will use monthly.
Out of time, Blanca, so we're going to have to go to the question and answer section. Okay, so we'll get started with that now. You have 2 minutes.
So you're charging the nursing homes? I'm wondering if you could maybe charge the testing companies.
So we were thinking of, right now we're thinking of the nursing home, but we have also explored that option. We thought that for now, we should target nursing homes because since we're planning to deploy pool testing, that actually means that it will be quite cheap because most of the time you will only, if a nursing home has around 200 employees, you would actually be using 4 tests per testing like batch or something around that, 4 to 6 tests we were thinking. So there's actually not that much profit for the testing companies. It would just be a massive cost reduction for the nursing homes.
And it seems like there's a lot of the data is self-reported. So I mean, how are you thinking about ensuring adherence that folks continuously input their data?
I mean, we mentioned that we plan to make this a like gamified a bit, so like really easy quizzes, and also there will be like competitions within different units in hospitals, meaning that units that do well can be rewarded with vouchers and stuff. And the fact that it's anonymized means that they shouldn't feel worried that the data is going to be used against them at any point because the hospital will only see the broad statistics.
We have about
one more, or if I have time.
About 30 seconds, okay. 25 now.
Can you break down a little bit more about the stratification and how you're doing it? Are you using kind of
Yeah, so currently the algorithm was built over this weekend relies on already available data, mostly by WHO and by research studies. And so we've created an algorithm based on that. Our next steps would be to like make it a machine learning algorithm through more available data.
And now we're out of time. I'm sorry, I know it's so ruthless. I apologize for that. So maybe you can continue the conversation later. And so our next slides can come up, and we have team 024 vBot, and the next one up is Sniff Today 029. So get on deck in 5 minutes. You'll be up. All right, team vBot. Oh, maybe we can switch to their slide. And team vBot, are you ready?
Yes, we're ready.
All right, Ning. So I'm going to hit start.
Hello, everyone. Do you want a robot to clean your surroundings, deliver food and medications, and chat with you? We are vBot, a versatile companion robot to minimize risk in nursing homes. Next. 1.5 million people live in nursing homes in the US alone. Over 35,000 nursing home residents and employees have already died from COVID-19. Imagine if you're a resident or family member, how would you feel? Would you be afraid? Next. Our goals are to minimize risks of COVID-19 transmission in nursing homes while increasing personal connection and companionship. Next slide. Our solution is vBot, an AI companion that will minimize COVID-19 transmission by delivering food and medications to residents. It will also sanitize the environment and itself through UV radiation and sanitizer sprays. It brings additional personal connection by chatting with residents, playing fun music, and facilitating communication between employees and patients. Next. Here's the demo of vBot. Could you play? Oh, sorry. So yeah, this is from the top is for UV radiation. The tablet, as shown is tablet, and also the trace for food and medications. We plan to spend 2 to 3 months to develop the final vBot and bring it to market. Next slide. vBot is a versatile medical companion robot to minimize risk. It delivers food and medications, sanitizes itself and the surrounding areas using UV radiation and disinfectants. It also brings personal connection by chatting with residents, playing music, and asking how the residents are doing. Next slide. For the business model, the global medical devices market is going to reach 16 billion. For vBot, the expected manufacturing cost is $1,000 approximately. Nursing home residents are the target users, and we plan to have one vBot per 10 residents. Next slide. Next. So this is the vBot team, and we believe that vBot will bring that personal touch to every nursing home resident. That's, thank you, and I'll take questions.
Okay, great. You had 10 seconds left. Good job. All right, so we have questions up next for 2 minutes. We started the timer.
How are you going to develop a robot in 2 to 3 months?
Yes, so we plan to have a line following robot with Pathfinder abilities. There are many robot companies developing innovations. But we want to integrate many aspects and do it cost effectively. Yeah, I think it would take approximately 1 month to do additional research and reach a prototype and spend 2 more weeks to develop a final prototype. And then for market approval process, it would take a month.
How many nursing home patients can one robot service?
So we plan to have one robot service approximately 10 residents. So if it's 2 residents per room, it will be 5 rooms, and we'll have separate vBots for like infected, suspected, and non-infected individuals.
45 seconds left for questions.
So I understand kind of how the UV aspect works, but how is the disinfecting aspect work? How are you spraying?
So we plan to, so the bottom of the robot contains disinfectant spray, and then also the top can just spray a little bit to like clean itself, and the food trace. Yeah, so I think we wanted to use disinfectant spray, especially during the day, because UV radiation can be harmful to people.
Okay.
Hi to Sandy.
Yeah, we have about 7 seconds left, but really good job. I hope your robot looks like that little icon there. It's really cute.
Thank you.
All right, we'll see you guys later. So then we have up next is 02.
Sorry.
Okay, so up next we have 029 Sniff Today, and then up on deck should be Team 20 Corona Valve. So Sniff Today, we can switch to the next slide, Alfonso, and if Sniff Today is ready. Do we have a team member from Sniff Today? Okay, are you ready to go?
Hello, this is Venkata, and we are Sniff Today, and yeah, next slide, please. From the onset of this pandemic, we have 42% of total deaths, fatalities coming from a nursing home. And there is a speculation and a research that could it be because of the silent spreaders, people who have the virus but have no symptoms or probably knowledge about the virus, and they're just walking vectors into these facilities. Next slide. So from our current knowledge, we know that loss of smell and taste have become the symptoms who can, early symptoms which can predict the coronavirus in spite of not having other traditional symptoms like cough and fever. So a person having a loss of smell is 10 times more likely to have this coronavirus. And there is also a Boston researcher developing a scratch sniff-based test to see if that could be an alternative cheap way of testing. Next. So what we are trying to achieve is a toolkit which has the scratch sniff-based testing and a dashboard to screen all these people who are entering the facility to prevent them from spreading the disease in the facility, capture all this data to predict future occurrences, and also help the facility to prepare themselves in case they have a shortage of the staff if they're contacted by the virus. Next. So how do we do it? So when the person enters the facility, he's given a blind sniff scratcher sniff test, which he could take it and then enter the input in the dashboard. And based on the report is positive, then he can enter the facility. If it is a negative report, he can meet the facility manager to whatever is the best means to do moving forward. Next. So this is our app based on like user roles and diagnostics, and you can see inputs and test, which gives an alert system. Next. So we also have a sensor diagnostics, which can have a temperature and heart rate. Next. Also, we have included the other vital symptoms like fever, cough, reporting system. Next. And an admin can actually use all this information to do analytics and also be able to predict, use this information on weekly or monthly basis for the possible positive coronavirus patients. Sorry, next. So how, because this app is actually made for facilities, so we are going to directly sell, it's a B2B product. Next.
Okay, you're out of time. We'll have to go to the questions now. Okay. So I'll start that. We have 2 minutes.
I saw that you had, you know, the other vitals included in the app as well with the cough and the fever, but it seems like the first point of diagnosis is going to be the smell, the scratch and sniff. So if the patient is, you know, has COVID, but might have a temperature and not these, you know, hasn't lost the sense of smell, is that somehow accounted for in this?
Yeah, I can take this question. So what we actually plan to do was integrate this into existing solutions, like maybe one of the previous ones. I think IR camera based kiosks are going to be pretty commonplace. So we are going to piggyback on them. If that doesn't really work out as a business strategy, then we will develop a similar solution for us as well. But I think the unique value proposition here is that ours is the only one in the market so far that's purely looking at the loss of smell as a sensor metric, and it's hard to measure.
So built on that point, given it's hard to measure, you referenced a Boston researcher developing this. How far out is that, and how contingent is your model on that research getting to completion?
So that research is primarily to see if at what stage the coronavirus presents with these symptoms. But the fact that it is a symptom is confirmed in more than like 60% of the cases. So the sniff test is actually used medically even now. So there is a protocol that's been developed and has been in use for at least 10 plus years by the University of Pennsylvania to diagnose anosmia. So we're just using that as well as the QR code to make it blind.
We're out of time now.
Yep.
So we'll move on to the next thing, the next team.
Thank you.
Yep, thank you. So the next team is 020 Corona Valve, and then we'll get MentaShield team 075 up. And then Alfonso, if we can just keep it up for a second to make sure that the judges can write down on their forms the team number that's currently up and then the one that's coming up.
And Alana, which one was?
Yeah, I want to make sure that I'm giving you the right one. So I will text that to you if that's okay. Yeah, I'm just going through the slide deck on my other side here to make sure that I've got the right number.
So the previous team was G029.
Thank you.
Sure.
Okay, so is Team Corona Valve, are you guys ready? Do we have our person? Okay, so if we can, yeah, you've got.
Sorry.
We'll just give her.
Okay, is it better now?
Yeah, that's much better. All right, so if we can go to her first slide, and then I'll hit the timer when we get there.
Okay.
Okay, Nishika, you're on.
34 cents for a better quality of life. Our team is Corona Valve. Next. So our problem statement. We want to address complications with wearing a face mask for extended durations in nursing homes. Next. Current complications with mask usage. Elderlies who already might have trouble breathing due to old age should be able to wear masks for long durations of time, but can't because of aggravating breathing issues. This causes infeasibility of recreational activities. Healthcare workers are wearing masks for long shifts. Mask covers breathing airways, which causes a lot of fatigue and discomfort. Next. What causes complications while wearing a mask? A survey for the Smithsonian Magazine said that humidity, breath resistance, and hotness are the three main factors. And as you can see, as the time passes by, it becomes more and more difficult. Next. Our solution. Our CoValve attachment reduces complications and upgrades the quality of life for the elderly and other populations while wearing face masks for extended periods of time. Next. You're probably wondering about safety. Our valve has airflow directed back towards the user so that their air is not directed towards other people. The damping mechanism prevents excessive projection of air, and a self-disinfecting copper insert is available with air-slowing chambers for healthcare workers. Copper is a great disinfectant because of its atomic makeup. Whenever a pathogen lands in it, ions puncture holes in the cell membranes and destroy the pathogen's DNA or RNA. Next. Design features. We have a one-way valve for easier breathing. It's compatible for most face masks and it can be reused. It's very lightweight, cost-effective because it's only 34 cents and it ensures quality of life by making recreation feasible. Next. Manufacturing and production. We would work with maker communities that are already manufacturing COVID-related products to produce our co-valve in a cost-effective manner. Next. Distribution. We intend on distributing co-valve to nursing homes by selling the blueprint online and letting them 3D print it. Since 3D printing is also getting more common, there are lots of maker spaces near nursing homes, which we would be able to take advantage of. Having the blueprint for this creation online would allow this product to go a lot of places super quick. Next. That's it. Thank you.
Okay, great. Just right on time. So we'll go to the questions now. You've got 2 minutes.
So are you intending to go to nursing homes first, or do you intend to make this publicly available and then eventually go to nursing homes after that for scaling?
We intend to first make it publicly available, so you can buy it online and then go to nursing homes.
And then would the nursing homes install it, like create the hole and insert the device, or is there instructions on how to do that?
Yeah, so basically the valve, it can be attached to any like normal face mask. So all you would need to do is 3D print it, and you can just cut a hole in your mask and just attach it so you can use it on any mask.
This is Susie. Do you have plans on how to navigate FDA clearance or approval of this product?
We still haven't thought about that much, but we will soon.
Okay, I might suggest if you're interested in joining the VA Maker Challenge that's ongoing right now. I've made a note on your judging form about that.
All right, thank you. I will.
We have about 40 seconds left for questions, comments.
I worry about the market, depending on the market to adopt it. What sort of standards are being applied now, and that if there's really demand for something better. I wonder how you can, help push that harder. That's more of a comment, I guess.
Okay. We'll think about that.
Before we move to the next team, I wanted to quickly note again, Nate, that was an awesome comment. Let's definitely capture those type of thoughts and reactions on the forum so that the teams get that post the event. That's one of the most valuable things that teams get out of participating in one of these events. In terms of, Susie, to your point on the VA challenge, we have a slide for that at the very end of the presentation so that everyone can learn about that a little more.
Wonderful, thanks.
And then Alfonso, I just had a quick question for you. We're going through all of these without a break, right? We don't have a break that's coming up?
No break, okay. No break.
Trying to make sure. I thought I was supposed to be announcing a break. I was getting worried that I was trapping everyone here. So no,
I think we're more than halfway through. So I think there's a light at the end of the tunnel. By the way, judges, that the team that just presented was team G20, 020. Now we're going to our next team.
All right, so we have team 075, MentaShield, and then up on the deck next is going to be team 004, Corona Vital. So Corona Vital, make sure you get ready. And again, that's team 004. Okay, MentaShield, do you have your person who's available?
Yes, I'm here.
Okay, it's a little low. Your audio is a little low.
Is it okay now?
It could be better. It's like you're far away from it, possibly in a wind tunnel. No, it's not that. It's not a lot of interference. It's just really low. But if that's the best you can do.
I don't know, what else could I change to?
Okay. Well, we can go ahead and get started. I don't know if you can just move the mic closer to your mouth at some point and see if that works, but we can go ahead and get started.
All right, should I begin?
Yeah, go for it. I'll start your timer now.
Hello, everyone. We are MentaShield, and we are here to address mental health issues in nursing homes. Next. Next.
Now, there is no denying the fact that there have been a huge increment in the number of mental health patients due to COVID-SARS-2, especially with the elderly and people living in assisted home facilities. These issues may be missed, firstly, due to underlying health conditions, and secondly, for the elderly, problems like depression can be mistaken for a normal part of aging. Next. The numbers clearly depict the surge in the mental disorders, including depression, anxiety due to extreme social isolation, fear of contracting the disease, etc. Next. It is known that early assessment and diagnosis can lead to great improvements in patients' health, and severe decline in cognitive functions can be avoided with early intervention and treatment. Next. We present to you MentorShield, an AI-based interactive platform for assessing and addressing the problem, customized for targeting individual issues. Next. The assessment will be based, with our interactive interface, there will be assessments through communication and or an interactive activity initiated by the AI integrated device like Alexa or Google Home. Next. The flow will go from the patient interacting with the Google Alexa device, which will lead to a set of questions or gameplay, which further will give an immediate suggestion that will be designed for that particular mood. Next. The assessment will be based on a set of interactive conversations day and night, and this will be developed with the help of behavioral scientists, therapists, or humorists to make it more interesting and wittier. It will be randomized, so sometimes they will have gameplay in this assessment part as well. Next. The immediate suggestion or solution would be games, streaming services, exercise routines, a video call with a loved one, or a mental enrichment session for uplifting their mood. Next. There will be a weekly report generation on a standardized matrix, which will be sent to a specialist who then will intervene with the desired solution, be it a therapy session or special instructions to the in-house care. Next. Our service model depicts different stakeholders. Next. The stakeholders, as I mentioned, will be technology providers like Google, Alexa, wearables like Apple Watches, service providers like online streaming services, content creators, platforms, and care providers. Next. This is scalable, so we should not limit it to just the elderly, but also could be used to address other demography like adolescents, orphanages, etc. Next. So
and you are now out of time. Thank you. We're going to go on to your question section. So we'll start your 2 minutes now. Thank you.
Can you speak to your business model and your milestone chart?
I'm sorry, I couldn't hear the question.
Your milestone chart and your business model.
I can take that. The business model is basically having the stakeholders provide content, and of course the payment would be coming from the nursing home itself and the care providers. But basically this is an ecosystem, so there will be a lot of content that will be created, and there would be a revenue share model for that. The milestones, we're expecting to have the early pilot and minimum viable product and ready by the end of the year, and going into a more commercial phase next year.
I see clinical trial on this page. How is a clinical trial required, and what are you going to do with it?
Given the actual nature of mental health assessment, we believe that we might need some kind of evaluation with existing techniques, such as a mini mental state examination or a psychological test. So we want to see how our assessment performs in comparison with the existing mechanisms of standard testing. And that's the reason for potential clinical trial.
Can you tell us a little bit more about some of the engagement models that you have to get the elderly using this?
Yeah, the engagement model would be, as I said, based on either they would go through a set of not necessarily boring
Your
questions.
time is up for this part, sorry. So we'll have to move on to the next team, but thank you. And maybe the questions can kind of continue a little bit later. So we'll go on to team 004, Corona Vital. And up on deck will be team 010, ACQM, air cleaning and quality monitoring. So you'll be up in 5 minutes or so. So team 004, Corona Vital, do you have someone available?
As a quick reminder for the judges, the previous team, that was team 075, G075. Apologies.
Okay, Corona Vital, who do you have up?
Yes, hi, this is Girish, I'm ready.
Okay, great. I'll start your timer now and we can switch to your first slide. And Ankita, can you mute yourself? Go.
All right, next slide. So coronavirus tests today are offered predominantly only to symptomatic people, but although there are data which is showing that there is, for every case of confirmed symptomatic case, there could be 20 asymptomatic individuals. Next slide. This can create actual complications in nursing home kind of environments, mainly because there is challenging infection control constraints. Residents have higher, older ages, as well as come with comorbidities, and employees actually are workers which jump between different locations and multiple shifts. Next slide. So why should the residents here then actually go to hospitals at all unless it's absolutely required for them to be there? Next slide. So our solution is to provide an affordable remote monitoring tool for early prevention and faster medical assistance wherever that's needed. Next slide. So we do this by creating a platform that integrates multiple vital signs and stream them to a live dashboard where care providers can assess individual patients and track them live. Next. So vital signs are actually advocated by national agencies as well as consortiums. There is also standard scoring mechanisms that have been created so we can do a multi-parametric assessment based on the vital signs itself. Next slide. And there has been accuracy studies which shows that the vital signs are from the wearable devices can do good real-time surveillance, and it can improve prediction by 32% or so for specifically influenza-like illnesses. Next slide. So there are existing commercial solutions for vital signs. Next slide. But for this hackathon, we have created a small prototype, which is based on a wearable headband. And you can see some of these different sensors that we have attached to it. Next slide. So the sensors data comes through a hosted server where data is extracted, processed, and then through a deep learning model that has been created with 1,000 records of synthesized data, we can then feed this into an inference engine that can be hosted on a dashboard. On our early testing, we see about 78% accuracy. Next slide. This is a real snapshot of an actual functioning dashboard where 2 simulated patients and their corresponding data is shown. Next slide. Our business model is B2B2C and the software as a service. Our initial pilot phase, which we're thinking of doing free, is to obtain data and gather evidences before going to a commercial. Next slide.
And now your time is up, Girish. So we're going to go ahead and go to the Q&A section. So we've got 2 minutes. Good job, though.
How are you going to beat the other platforms out there? Fitbit just announced that they were going to be doing a big study. Aura's doing one with UCSF. Bioformus has been in this. What makes you better, and can you get to market and outcompete them?
So the analytics platform is something that we already, as I said, have been able to create in the last couple of days with synthesized data. And we have actually already applied to get some public source data so that we can actually try it on realistic data sets. So that's the analytic part. For the actual hardware itself, we could integrate with any commercially existing solutions, Fitbit or any of those that can provide the data to us. Or the purpose of creating the headband was to try on actual realistic wearable solution that can work with it. So both these solutions are actually integrated together.
So, okay, so just to double down on that, are you a hardware company or a software company then? We're
primarily a data analytics solutions company. This is a platform here.
Okay.
So just on the business model then, so is the idea to, you're agnostic towards the actual wearable, though you have one if you need it, and you want to focus on the data analytics piece.
That is correct, yes.
About 30 seconds
And
more.
the vitals you've selected to measure are based off of.
Yeah, these are based off of studies and guidances provided by CDC, FDA, of standard techniques, standard measurements that are typically shown of high significance. We do have a chart for the timelines and estimates of how we can go through.
So we just have a few seconds left. So thank you so much, Girish. Your presentation's really a lot better. Thank you. All right, so with that, we'll end. And we're gonna go to the next team. I'm just gonna, sorry, I have to change my screen a little bit here.
As a quick reminder, this past team was G004.
Okay, and then we've got G0010 ACQM, and then up on deck should be team 008 COVITANs. So you'll have about 5 minutes, COVITANs, to get ready, and then we're ready for ACQM. Do we have someone on board?
Yeah, this is Shamir.
Okay, great. Hang on 1 second. Sorry, my timer's on the wrong thing. All right, I'm gonna start your 3 minutes now.
Yeah, started?
Yep.
Yeah, myself Shamir, and I'm a registered nurse and having a global health background, and my team consists of engineers, biomedical and industrial engineering. We are talking about the poor indoor air qualities associated with the increased mortality in the nursing home. And there is a huge literature out there. Poor indoor air quality is associated with the increased mortality in the nursing home and the long-term healthcare facility. There are many personal stories coming from the field. Next slide, please. And coming to the US nursing home, and the LTC contributes 50% of the total death in the 15 states in the United States and in the UK. And poor air quality inside the nursing home and long-term health facility, plus comorbid health condition, how we have to acknowledge that fact for the mortality. Next slide. And there's a research evidence coming from poor air pollution particles may be acting as a vehicle for viral transmission in the nursing home and then long-term healthcare facility. And it appears to be occurring through airborne aerosols. Next slide. How do we solve the problem? Our team, after brainstorm discussion and extensive research, we came up with a solution like developing highly efficient air filter based on electrostatic precipitator technology. And this technology is flexible and extensible. And we offer two possible applications like air quality, air supply system cleaning and monitoring, and creating an airway space between individuals like AirBlade. Next slide. This is a picture. Next slide. And our technology is installed with the upcoming existing facility. And then we are focusing on electrostatic filters is around, and the picking capacity is like 50 to 70%. Next slide. And benefit, the value we are creating, we are improving the total quality of adjusted life years lost, and then it can be applied for the similar respiratory illness. Next slide. We will be partnering with the LTC and then other nursing homes, and this is the creating airspace between the two individuals. It can be applied in the caregiving space like operating room, emergency room. Next slide. And look at the picture, and here you can see the down where the air is coming, and then at the middle part, it takes the purification, and then it emits the pure air in the indoor facility. Next slide. We are significantly focusing on public health importance, and it can be scalable and it can be applicable in lower resource constraint settings, and then including the nursing home and long-term healthcare facility. And believe that tackling this problem, we could solve the potential impacts.
Thank you. Right on time. All right. So now you have your 2 minutes for feedback, and I'll start the timer now. Good job, Shamir.
I can take a stab at this one. So, there's two components, right? One is the air droplets in the air itself, but then the second component is stagnant air, right? So, how do you address the stagnant air piece and continuing the airflow? I know you're helping, with the first piece, which is kind of removing the particles from the air itself.
Well, I will answer this question. Actually, any air intake coming to the air inlets is equipment. It will purify and clean the air. So usually in any room has an airflow, especially in LTC, and even it doesn't have, and we can equip this equipment with fan and just make a continuous airflow, continuously purifying the air in its environment.
So are we asking these facilities to replace their HVAC systems, or is this on top of existing systems?
Actually, we are very flexible and we can fix this equipment any
living space.
Yeah, any retrofit to any space, like existing HVAC system could be equipped with air outlet parts, supply nozzles, or if we have a purpose-built building, we can put install in the integrate in the HVAC system, or even in buses, we can make an air blade between driver and passenger cabin, so it will be just isolated by forced clean air. It will be exceed pressure, but any particles coming in will be pushed out.
We're done with the question and answer section. Thank you so much. And so we will move on to the next team. So if we can advance the slides. So
just reminder on the number for the judges, G010.
Thank you, Alfonso. And then we have team 008, Covitans, and up on deck should be team 038, Pro Shield. So you have about 5 minutes, Pro Shield. And then Covitans, Kruti, are you going to be presenting?
It is Candice. Yeah, I will be presenting.
Okay, Candice, are you ready?
Yeah.
All right, so we're going to start your timer now. You've got 3 minutes.
Sure. Good afternoon, everyone. This plot is showing you the distribution of nursing homes in different regions across the country. And I want to start with one question. How do we allocate resources based on regional needs if we already knew the location of the nursing homes? Next. 42% of the total COVID-19 deaths happen in nursing homes. How do we protect the most vulnerable group nationwide as well as the staff members? Next. In many states, while nursing homes can request for PPE, they are not getting what they need. First of all, they don't have a matrix of how many PPE each nursing home needs. Second, they solely rely on the state government stockpiling and the traditional supply chain, which wasn't designed for a pandemic. Nursing homes believe that the state government may have a stable supply and PPE will be distributed according to their needs without any disruption. Next. Our project is to predict the resource allocation for nursing homes. We are COVID-10s. We have 5 members. I'm Candice. My teammates are Kruti, Nadia, Han, and Aparna. Next. Our goal is to design an algorithm that can predict the amount of PPE resources required at a particular nursing home for better resource allocation. This serves 2 purposes. One, we are providing an algorithm on how many resources they need to address the current problems on stocks. Second, we later on want to look at the supply chain based on the regional level to identify the sources where they can get PPE or whatever resources that they need outside of the state supply chain. Next. We have already collected several data sets on the nursing home staff and resident numbers, and also nursing home infection rates. One of the data sets that we're still looking forward to get is the number of PPE, medications, and ventilator usage in every single nursing home. Next. Our predictive algorithm makes use of phase 1 PPE request data, infection rates, death toll, and staff number from states to input and as an input to train a model to predict resource allocation outcome. There are 4 important pain points that we have to address. First, PPE usage. Second, acute care and nursing staff numbers. Third, the atypical symptoms that we found on elderly people. Fourth, and the ventilator usage. NYU has already reported statistics on how many ventilators they needed at peak. One thing that we also have to notice is that our senior citizens may present atypical symptoms. We want to have a sufficient amount of medications and ventilators ready whenever it is needed. That is also a reason why we want to look at later we want to input ventilator usage, medication usage, and medical professional headcounts related information estimated needs on other medical resources. Next. When the traditional supply chain failed, we are going to act as a trusted partner to governments, nursing homes, and assisted facilities to identify them.
So we're going to stop you right there, and we're going to move on to your question and answer section. So you'll have 2 minutes. Go ahead and get started.
I think you were getting to it, but who uses the algorithm? Is it the homes or the government? I'm struggling a bit with like where in like the decision matrix this gets placed, that it has that it really moves the needle in terms of reallocating resources.
I can take that. So currently we are thinking the government will be using it, but this can be further used by supply chains and also the nursing homes. So they get ready. If there is phase 2, they would know how much of PPE will be required.
So just so I'm clarifying here, you're using CMS data to input into the algorithm, right? Is that correct?
Yes.
Okay. Have you thought about the differentiating factors then of what you would be bringing versus the other competitors on the market that are doing much of the similar work that you proposed here? So tell me a little bit about the landscape.
Yes, so we are going to look at the location. Every location is unique, right? The nursing home with 100 beds in New York or Connecticut, how much PP they would need would not be required by a nursing home in Wyoming. So that would be an indicator. We would also be looking at comorbidities of the residents and also the age factor and probably the other demographics. So we have looked at a few of the features, but we can expand on that.
Okay, there's about 8 seconds left, so I think we'll end there. And if we can advance the slides and get ready for our next team.
Thank you.
Good job, you guys. You did a really good job.
Thanks.
Team 038, ProShield is next. And then we're gonna have team 014, Cross Paths, get on deck. So ProShield, do you have someone who's ready to present?
Yes.
Okay, so if we can advance the slide to theirs, then I'll go ahead and hit start when we see the slide.
Yep, just as the quick usual reminder, I'm trying to give judges. Sorry. That's okay. Previous team was G008, and this upcoming team is obviously G038, but G008 to the previous team. Okay, now we're gonna get ready.
Thanks. All right, push hit start.
Okay, my name's Margaret. Thank you. I'm representing Team ProShield. The mission is to protect nursing home residents through a simple, proactive reverse contact tracing app. Next. Next. We know that COVID is transmitted easily through incidental human contact and is often brought into nursing homes through asymptomatic carriers. Next. Our goal is to identify potential chains of transmission before reaching the nursing home. But start with the nursing home residents rather than from a COVID positive person. ProShield is kind of a simple idea. The person in contact with a nursing home resident would proactively send alerts to their closest physical contacts through the ProShield system. Contacts could send back alerts of their status concerning sickness and testing. Next. ProShield enhances the practice of contact tracing by making it proactive before someone gets sick. It's voluntary, it's anonymous, secure, and private. Typically, a user would use it before visiting a loved one. Next. So a typical scenario, if you want to visit someone, you would just send an alert through the ProShield system. And if you got all contacts back that there was no sickness, you'd feel better about your visit. Next. In regular contact tracing, the sick person is asked to name their recent contacts for testing and quarantine. It's widely used in pandemics and epidemics. Next. So it was used extensively for the Ebola virus epidemic. Next. In proactive contact tracing, a healthy person with close interactions with the vulnerable can send a ProShield message to their close contacts. Again, it's voluntary secure. Personal data is not collected, just emails and phones, and contact data would not persist for longer than an incubation period. Next. So here are the basic steps of how the system would work. You can invite your nursing home residents or staff or visitors to nursing homes to join the ProShield system with an online form. You would sign up for ProShield with just your name and email address. Each invitee will receive a message giving them the option of inviting their own contacts, names and email addresses. And then if you were diagnosed with COVID or have early symptoms of a sickness, you can send anonymous downstream sick alerts to your contact chain. Next. So it would basically cost very little to nothing for nursing homes to use. Next. It would be HIPAA compliant, and it would protect nursing home workers as well as staff. Next.
We're now out of time. Thank you, Margaret.
Got it.
We'll move on to the next 2 minutes for Q&A. We'll start that right now.
I don't know if you're just getting to that, but I was just curious on the actual business model of, who would pay for the development of the product and maintenance.
Right.
I can take that.
Thank you.
Can you hear me? Yeah. So one thing that this would do is it could prevent major outbreaks in nursing homes. So I think that even insurance companies have an incentive in terms of saving healthcare costs to help fund something like this. I also think that there's nursing homes that aren't resource poor who would be able to chip in money for the development of something like this. And we already have a working prototype that was built by Margaret. So really the main cost would be making sure that the temporary sick alerts are secure and encrypted and not and HIPAA compliant, basically.
That's cool.
So given that this is something that you're opting into, what was the reasoning behind the anonymous piece? So why keep the person who was sick anonymized from the users?
Yeah, that's because in typical contact tracing, so I'm an epidemiologist, in typical contact tracing, they don't want to give stigma to any person who's sick. So it's kind of a protective thing for the sick person so that they feel less ashamed of sharing the fact that they're sick.
Right. In the typical piece, it makes sense, right? But here this is like your inner circle or people that are associated with you, right? So just curious about why you chose. Was it just to keep the stigma?
I think that by inner circle could even include colleagues that you work with day to day. So for example, like the close contacts that you include in here aren't just people that you're close with emotionally, but people that you actually interact with within 6 feet throughout the day. So it would include a bunch of people that you aren't necessarily close to emotionally, even though you are proximal to them physically.
And with that, we're done with this part of it, and we're going to move on to the next team. But thank you so much, ProShield. You guys did a great job.
Thank you.
Mm-hmm.
Our usual reminder, this past team ProShields was G038. G038 for judges.
And now we have team 014 coming up, cross paths. And then on deck, we should have team 023. So if you're all present here, handless, you need to be prepared to present in 5 minutes. And then cross paths, do you have your presenter ready?
Yes, that would be me.
Okay, so I'll go ahead and hit start, and you have 3 minutes starting now.
Thank you. Welcome. Let's talk about vulnerable communities in COVID-19 stage in US. We found that care facilities are high on infection rate. The stats for death in US have been the eye-opener. While 42% of the total fatality in US reported due to COVID, they have occurred in care facilities. In Minnesota, it was 81%. Brings us to one question: how safe are we? Next slide. Next slide. Okay. We bring you CrossPath, one platform that will calculate a score, susceptibility safety score for letting anyone enter the care facilities. Our feature talk about risk mitigation score and if existing serology data along with other data. The safety score is calculated using various input. One of such is questionnaire. We designed the questionnaire using factors that are highly correlated in susceptibility of COVID-19 transmission. We also made sure that the questionnaire is aligned with WHO and CDC regulation. Next slide. So how do we find the score and where do we use it? We calculate the susceptibility score by creating a function that takes in data sources, contact tracing, both from smartphone and feature phones, questionnaire, data from patient, in-care facilities, senior citizen, and healthcare workers entering the facility. And finally, the demographic, RT-R0 and PPE availability data of the care facility. This score will be used in 2 tracks. One, admission to the care facilities, and susceptibility safety score plus social distancing, which is integrated with what 3 words, a GIE-based tool. Using this integration, we plan to bring the physical routes as virtual track to be maintained as a safe track while walking inside a care facility. Next slide. Our value proposition. So our value proposition is moving from asking questions to actually making prevention. We start with Ask, which is an app interface, and move to a calculation of risk score. Then we move to care facilities integration, and then to define smart routes. Once we have enough data, we'll look into PPE inventory and move towards creating one consortium of all care facilities. This entire solution will be deployed at care facilities, and we'll look ahead to partner with testing facilities for deployment. The revenue stream would focus through getting partnership with testing centers and care facilities. Next slide. How did we initiate our research? It was who is at greater risk. We created a quantified model. We created 2 questionnaires for health workers and for resident, and then we assigned risk score. Next slide. This is the modeling approach, which we conducted over 15 responses. As we can see, we have features that are really important in deriving the risk score. Next slide. In continued approach, we use random forest to find the risk scores. And we found, and we'd given a risk score, whether it's 1 or 0. Next slide. So we are the brains behind the path, and we thank MIT and our esteemed mentor for giving us this opportunity. Thank you.
You're done, thank you. So we'll start your 2 minutes of question and answer. Good job.
Thank you.
What do you think has to happen in the US for this sort of thing to be deployed? I mean, this sort of reminds me of what, you know, the way they were doing it in China, where you'd have to be green to enter certain areas and whatnot. I worry that in the US that a lot has to change to make this sort of thing happen.
Yes. So in China, after Wuhan incident, and there's a research which is actually, and what really inspired us, because there's a research right now which is taken up by CDC, like how to control the next pandemic, the second wave which is coming up, and they are working on a host susceptibility score to severe COVID-19 and establishment of a host risk score. That inspired us that if US is working on a host risk score to identify that which patients are going to the next stage in the pandemic, we also defined that how we can take that score versus the demographic and the people who are coming in, and then we map it and give it to the care facility. And that could be inspired for all the care facilities in US.
And it seems like, you know, you're capturing the data by the first input of the data is coming from, you know, the user inputting self-reported data. Is there a thought of potentially trying to make that a little bit more objective? Because, you know, patients can, depending on how they're feeling, could provide data in different lights, depending on how they're feeling in terms of reporting. So is there an objective way to capture that data or on the roadmap, or are you thinking about that?
Yes. So the capturing of the data, initially we start with questionnaire, and basically this questionnaire is the data will be captured direct from the health worker who are entering the facility, the visitor who are entering the facility. And the other point of the data is through the contact tracing as well as the thermal scanning. For the patient, we are looking at clinical data as well.
Okay.
Oh, okay.
Sorry. Thank you, Krishnendu.
No,
okay.
Thank you.
So, yep. So good job. I will have us move on to the next team, and then this one, I guess we can show that slide again.
I have it up on my side. Crosspaths was team G014. Not shown on the slide right now, but team G014.
Okay. And then this group coming up is G023 handless. And so they should be on now. And then 012 live connected or live connected. If you can get on deck and be ready in 5 minutes. All right, handless, are you ready? Do you have someone on?
Yeah, can you hear me?
Yeah, we can hear you well.
Cool.
All right, I'm gonna start the timer now.
Thanks. So my name is Logan. I am a co-founder of Handless Door Opener, and our mission is to keep people safer by reducing transmission via surface contamination. Next slide. So people already hate touching the restroom door handle when exiting. In the COVID era, people should hate touching all door handles. According to this study, one virus-contaminated door handle can infect 50% of all staff and visitors in the building within just 3 hours. Millions of people assume the risk of touching COVID particles and other germs each day, and the elderly especially need to focus on prevention. With out-of-stock cleaning supplies and understaffed crews, we asked ourselves, was there a way to avoid contaminating the handle in the first place? Next slide. So our solution is a foot-operated door opener. You use this device by pushing up on the internal pedal with your toes. This pulls the handle down and unlatches, and then you can swing back to open the door. The pedal also has a copper plate to ensure self-cleaning. That's something we're considering. Next slide. And then you can play the video if you would, please. Ideal implementation is a door with a latch handle and auto close functionality. This completely eliminates the need for hand contact with the handle. Next slide. Constant disinfection showed by the Clorox logo is an ongoing cost that requires manpower to buy and use several times a day, yet still retains some risk of transmission. Step and pull does not have the functionality to unlatch a door, so its scale and impact is limited to a fraction of our door openers. Next slide. We will be selling B2B, exploiting our professional networks until we get enough validation to pitch to distributors such as Cintas, Ecolab, Walmart, or even Home Depot. Customer acquisition will begin after we launch a pilot study in the next week or so, but we do have a few companies already interested in Europe. Next slide. We have a small investment from winning the Johns Hopkins Design Challenge back in March, and we have applied to a couple accelerators. Our revenue streams are from direct sales to a target audience of healthcare and other corporate buildings, universities, and of course, assisted living facilities. After building a customer base, we plan to source most of our revenue from the channel sales. Next slide. We are seeking connections and support from MIT. Our next steps are prototyping and copious user testing, then an initial manufacturing round. Next slide. Our team skill set is comprehensive of essentially every engineering specialty, along with entrepreneurship and patent law. We were united under the National and Royal Academies of Engineering University programs. We have added strength by being able to realize the impact of COVID-19 in our own lives, but also from each other's global perspectives. Next slide. And with Handless, we can stop the spread, reopen the economy safely, and also reduce disinfection costs. And I can take questions.
Okay, so we'll start the timer now, 2 minutes. Good job, Logan.
So just trying to get a clarification on the mechanism. So you push down on it, and then do you use your foot to kind of swing the door open, or does it actually swing the door open itself?
So you put your foot up against the pedal. You actually push up with your toes. So if this is your foot, you'd go up with your toes and then push, pull out backwards. And your toes kind of catch on the device and allow you to swing it out.
Swing it out.
Does that make sense?
Got it. Makes sense.
Okay.
What else is out there that you mentioned step and pull? I would have to think that there are a lot of different foot operated door levers.
We actually haven't found any like this. Of course, there are the motion activated ones, but we really wanted to focus on something that could be implemented and produced immediately for the most immediate impact really for the pandemic.
What does manufacturing look like for this? What exactly are the components you would need, and how quick could you make those?
Yeah, so the product will come in a kit. It has, it's a modular design, so it'll be screwed together very easily by the person who buys it. And then it'll come with mounting strips, like double-sided mounting strips. You just stick it on your door. For manufacturing, we're thinking of laser cutting if we're gonna go with plastic. We are also considering an aluminum model for like sturdiness and easier to clean.
Have you considered ADA requirements and things like that, fire egress, considerations as well?
Yes. So I did look at ADA requirements. The only thing for a door attachment is that anything has to be attached to the pool side of the door, and the other side has to be smooth.
Unfortunately, we're out of time for that part of it.
Thank you.
Okay.
As a reminder for judges, this team with the number of G023, G023.
Okay, and then team 012, Live Connected. And then after that, we'll have the VHA Innovation Ecosystem slide that we were provided by Ms. Shirley. So Live Connected, do you have a representative available? And then we'll go on to the VHA slide from our judge. So I guess we can move forward. Oh, and then, right, we needed to tell you what the number was again.
Yeah, G012, G012. Okay, so next, I have a few appendix slides. And maybe, Susie, maybe you could provide the percent on this slide unless there are other representatives from the VHA Innovation Ecosystem that would want to do so.
Well, I'm happy to talk about it, but let me first just ask, is Danielle Precora on the line right now? She is the lead for this event, and I believe she's in this track right now.
I can check. No, Danielle is not part of the participant list.
Yeah, I'd be happy to give a little update. So we in the innovation ecosystem with the VA have partnered with MIT, COVID Challenge here to offer another event. This is more of a maker challenge. So especially those of you who have devices and products that you wanted to, build prototypes and design and develop and pilot perhaps within the VA, this would be a great opportunity to join this maker challenge that you see here on the slide. The point of contact for this is Danielle Precora, and what I'll do is I'll just put her name and email in the chat, and mine as well, so feel free to reach out to us if you have any questions. Thanks.
Thank you.
Thank you so much. And one thing I'll highlight as well, and we'll hear about this in a little more detail later during the award ceremony, but a key aspect of these events of the MIT COVID-19 Challenge is to enable teams that participate and form during the weekend to get post-hackathon support. So our team dedicates a lot of effort, and we'll have structure in place for you to engage with this type of opportunity with the VA, as well as with many of our partners. Those partners that we have on the slide here are partners that have been, the expectation has been set that part of it, partnering with us in the MIT COVID-19 Challenge, is not only to help put together the event, but most importantly, support the teams that come out of the event, so that you as a team, either you win or you don't, it doesn't really matter, you can have an impact on this crisis, which is the reason why we're all doing this. So that, back to Alana.
Okay, so thank you everybody for coming. So I think the next step, everyone can turn off their mics, but the next step will be deliberations, and the judges and the organizing folks here will go away for a little bit and get prepared for all of that. And then we'll award 4 teams that we think did a job that, at least for this hackathon, merited an award. And we'll let you know who those teams are at 4 p.m. at the award ceremony. And then just to reiterate what Alfonso said, all of these providers and partners rather are here for you guys. And if you want to continue afterwards, you're certainly not limited to winning an award to continue. So Alfonso, is there anything else that I need to add that you can think of?
Not that I need to add, but I like to highlight it because it's not evident, I think. The fact that we're going to be in a separate Zoom room for the final award. It's going to be a webinar, going to look a little different, but you can access it through the link that you see on the screen, as well as this link will be made available through the general announcements channel, if it hasn't already. With that, we're going to be wrapping up this session, and for the judges on the line, we will be We will be setting up a different Zoom room, I believe. Is that the path, Alana?
You know, that's what I'm trying to look up right now. So I guess if all the participants can go away, and then we will sort out the Zoom room for the next steps.